So what I'm going to discuss with you now is the cardiorenal protection in type 2 diabetes and what we have learned for the many important studies that we have had the opportunity and the fortune to see the results over the past few years. These are my disclosure, the same as the one that I presented before. Now, let me just remind what is the current scenario in terms of the complication in people with type 2 diabetes. These are results from the NIH which is this survey that really keep an eye and screen the health of adult individuals in America. And what is shown here is the change in the prevalence of diabetic complication over the past, let's say, 30 years. You can see here different columns representing the period going from 1988 to 1994. A second one, a mid-term, from 1999 to 2008, and then the final observation, which is, let's say the past decades. And what you can see overall here is that in spite, the new opportunity, the new pharmaceutical opportunity we have, there's not been major changes in the rate of complication. Yes, you can claim that there is, some change here in terms of CKD or in terms of the albumin creatinine ratio, but again, exactly, most of this CKD reduction is due or associated to reduction in albumin excretion rate. But when you look at, for instance, the glomerular filtration rate, the impairment of glomerular filtration rate, this is not very much change over the past 30 years, as there is no major changes in terms of cardiovascular disease. So CKD and cardiovascular disease remain a major problem in our population with type 2 diabetes. And particularly CKD is becoming a more and more worrisome problem and a more worrisome problem at the worldwide setting. It is currently calculated there are something like 850 million of people with CKD, which can be calculated at 1 in 10. And even more, CKD is going to be more and more a leading cause of mortality in the general population. It used to be the cause in the ranking, of course, of that in the 19th place back in 2013, but it is estimated to escalate up to the 5th position in 2040. Now, the reason that I'm referring to the overall problem of CKD is that this CKD and this increase in the CKD is largely driven by diabetes. Among many other conditions, diabetes is a leading cause. In fact, it has been calculated that more than 40% of the CKD is due to diabetes. You can see here the distribution of the causes of a CKD with a high blood pressure, unknown other, but you can appreciate how diabetes really represented the major condition. And what is the problem here is that diabetes and CKD are a major driving mechanism, driving force for the risk of cardiovascular disease. This is the RIACE study. It is an Italian study, a survey that has been carried out in close to 16,000 people with type 2 diabetes that have been stratified in terms of their kidney condition. You can see here people without kidney disease, stage 1 and 2, 3 and 5, or 3 and 5 with albuminuria. And you can see that, moving from one stage to the other stage, there is a progressive and linear and constant increase in the percentage of people with major cardiovascular disease events. So the two conditions are very much connected. And also, we know that the CVD can be an early manifestation in people with type 2 diabetes. In this survey that has encompassed a large number of individuals with type 2 diabetes, has been evaluated what is the main manifestation of cardiovascular disease in people with type 2 diabetes. And you can appreciate that, among this, one of that tend to be the very first to appear is peripheral artery disease, but also the other atherosclerotic cardiovascular condition are very common. So again, confirming an increased risk in this population of people with diabetes as compared to the general population. But also, you can appreciate with the same rate of a manifestation, of cardiovascular disease, atherosclerotic cardiovascular disease, we also have an early manifestation of heart failure. And again, not only CKD is linked to cardiovascular disease, but CKD is strongly related to heart failure. In this geographical analysis, including England, Germany, Japan, the Netherlands, Norway, Sweden, so really representing a vast distribution of geographical distribution, what can be shown, what can be calculated, what was observed is that the first manifestation of cardiovascular and renal complication tend to go head to head when you do consider cardiorenal disease as an HF and CKD. And doesn't matter, where you stay, where you are. This is the same for all these conditions here, with a 60% of the cardiorenal disease, being the first manifestation. So once again, suggesting that there is a strong interlink, interassociation between cardiovascular disease, heart failure, and chronic kidney disease, which is not just an epidemiological overlap of the condition, but most likely is the reflection of a common pathogenetic dysfunction. We know that diabetes can lead to hyperglycemia, to hypoglucose toxicity, to oxidative stress, to endothelial dysfunction, which are drivers for atherosclerosis, myocardial dysfunction, and heart failure. And once that disease occurs at the level of the heart, that also will feed back to other conditions. But also diabetes through hyperglycemia and the same mechanism can lead to impaired renal dysfunction, to diabetic nephropathy. Now, the heart, through the activation of the sympathetic nervous system and the RAS overactivation, can also contribute to worsen insulin resistance, so generating a sort of vicious loop, a vicious circle here. And again, also the heart will feed back into the kidney, worsening the kidney function through low cardiac output and vasoconstrictive mediators. And of course, the kidney also will participate in this process through chronic inflammation, sodium and water retention, and so on and so forth, and through that feeding back into worsening the metabolic dysfunction as well as worsening the cardiovascular function as well. So you can see here that all these conditions are strictly interconnected. So it's a vicious cycle, but we have now multiple opportunities to really try to break this vicious cycle by acting at the level of the metabolic core, the diabetes, and directly acting at the level of the kidney, and also directly exerting a beneficial effect on the heart. And you can also appreciate that many of the factors, many of the pharmacological interventions that can act on one side can also act beneficially on the other sides as well. And just to give an example, what we have learned from landmark study, for instance, we have learned from the Fidelity, which is a pool analysis of the major trials that have been performed in people with and without diabetes with finerenone, showing that finerenone can be quite effective in reducing the composite cardiovascular endpoint, to reduce the rate of hospitalization for heart failure, to reduce the kidney outcomes, and also to reduce the risk of ending up into dialysis. So finerenone is an opportunity. But even more than finerenone, I think that we have strong evidence for the new classes of glucose-lowering agents in terms of providing, in terms of supporting beneficial effect in the cardiorenal perspective of people with type 2 diabetes. We have now 10 trials, including more than 17,000 people with type 2 diabetes, that have tested the efficacy and safety of GLP-1 receptor agonists in terms of their cardiorenal action, and showing that the GLP-1 receptor agonist can significantly reduce major advanced cardiovascular events, can reduce in a significant manner all-cause mortality, can reduce the rate of hospitalization for heart failure, can reduce the composite kidney outcome, and without any significant heterogeneity of the drug route, because in this analysis, both subcutaneous and oral GLP-1 receptor agonists have been evaluated, and with an overall good safety profile in terms of hypoglycemia, risk of retinopathy, pancreatitis, cancer, and so on and so forth. So GLP-1 receptor agonist has provided an opportunity, as a great opportunity, particularly when you consider heart failure and kidney disease, as being provided by the cardiovascular trial, evaluating and assessing the potential role of the SGLT2 inhibitors. This is a sort of very simple summary. I like to draw your attention here in these last two columns, because both in terms of hospitalization for heart failure and in terms of kidney composite outcome, any of the SGLT2 inhibitors that have been evaluated has resulted in a significant reduction in the risk of this condition here. So this data has been taken up, has been informing writing groups in terms of the guidelines, and this is the most recent ADA-ESD consensus on the treatment of hyperglycemia in people with type 2 diabetes, where we highlighted that it's important, together with addressing the need for sustained glycemic control, more focus on the weight management, assessment of the cardiovascular risk factor, and evaluation of organ end stage, particularly in those individuals presenting with an organ damage. There are specific recommendations of using GLP-1 receptor agonists and SGLT2 inhibitors in terms of atherosclerotic cardiovascular disease, with a specific and more preferable indication for SGLT2 in the case of CKD or in the case of heart failure. But this is recommendation for people with an organ damage. However, there is also the view that these new treatments may be seen as disease-modifying treatments, to the point that a group of people, including myself, but also including Dr. De Fronzo, who is here with us, came together with what we call the simple approach. But the main message of the simple approach is that if we have disease-modifying treatments, those modifying treatments should be considered early on, at the time maybe of the diagnosis, considering the potential of combination together with metformin and the use of GLP-1 receptor agonists and SGLT2 inhibitors, with the goal of reducing the risk of ending up with major complications. Now, one of the problems with this view, which I agree very much on, is that the information is derived from the cardiovascular outcome trial. So it's important to realize and to examine what is the population that have been enrolled in those trials. And here is just a summary of the population, shown here in orange, people with established cardiovascular disease, and in green, people without an established cardiovascular disease. In other words, people with a much more advanced condition, and people very closer to what, if you want call primary prevention. And you can see that out of many trials, only a few have incorporated sufficient number of people without established cardiovascular disease, namely for GLP-1 receptor agonist Rewind, and for the SGLT2 inhibitors, Declare using dapagliflozin and Credence using canagliflozin. So it may be interesting to see to which extent, even in these people with a milder cardiovascular risk, cardiorenal risk, this treatment may provide benefits. Let me just remind you, for instance, in the Rewind, there was no difference in terms of the benefits with the presence or absence of a history of cardiovascular disease. There was no effect in terms of the duration of the disease, because the effect was the same in people with a long duration of disease, more than 10 years, or people with a short duration, less than 5 years. There was no difference on the basis of the starting baseline glycemic control, as indicated here by people with an A1C below or above 7.2%. The same when you do consider Declare. In the Declare was done an analysis. An analysis was done to try to evaluate what is the implication and the effect of the duration of the disease, duration of diabetes, in terms of reduction of the risk of cardiovascular death and hospitalization for heart failure. And you can see here that the two lines, the placebo, the red one, and the blue one, the dapagliflozin, were completely and remain separated irrespective of the duration of diabetes. So it may suggest that indeed this can be modifying factor, modifying the treatments that can be applied early on during the duration, during the stage of the disease. However, we also needed to acknowledge that the total number of people without major cardiovascular events remains small in the overall analysis here. So it may be important to do an even greater analysis using a pool analysis. And this is another example for canagliflozin reporting, the same kind of result in terms of the duration of the disease. And this kind of approach is the one that has been adopted by Dr. Palmer, that has really performed a network meta-analysis, including as many as possible data and cardiovascular trial, and they have stratified the population on the basis of the risk, defining people with very low risk, with no or less than 3 cardiovascular risk factors, people with low risk, moderate risk, high risk, and very high risk, those people with cardiovascular disease and chronic kidney disease. And they have done a number of analyses, and then just give you a couple of examples. This is, for instance, the non-fatal myocardial infarction. Here you can see here the first column is people with very low risk, and the dark column here is the people with very high risk. And you can see here that, with the increasing in the risk, there was a progressive major benefit that is carried by both SGLT2 and GLP-1 receptor agonists without very much of a difference when you do compare the two as far as non-fatal myocardial infarction. A little different story is when you do consider stroke, where you can see that GLP-1 receptor agonist seems to be associated with greater effect in terms of reducing the risk of the stroke. But what is interesting here is, once again, is that people with low risk have the lowest efficacy, while the people with the higher risk have the greater advantage on the use of GLP-1 receptor agonists with respect to non-fatal stroke. The other way around is what we can observe for hospitalization for heart failure, where it seems to be more apparent with the use of SGLT2 as compared to with the GLP-1 receptor agonist, as you can appreciate here. But once again, seeing a sort of a dose effect in terms of what is the overall risk and the benefit, being the benefit at the greatest in people with the highest risk and the lowest in people with the lowest risk, as can be people in the early stage of their disease. And actually, these authors concluded with a sort of recommendation. And their recommendation is that, based on their analysis, for people with a very low risk, there is no evidence of using SGLT2 inhibitors or GLP receptor agonists. This is their conclusion. But I think this is a biased conclusion. Let me just try to explain myself in a more specific manner. Here again, you may remember how they have split the population in terms of the risk. Consider people with high risk. Who are the people with high risk? These people are people with chronic kidney disease. When we speak about diabetes, we can easily translate that in people with diabetic kidney disease. And diabetic kidney disease is a complication of diabetes that I like to try to reduce as a risk as much as possible, because it also carry increased cardiovascular risk, as I already mentioned to you earlier on. And this is even even more interesting if you do consider that we have now more and very effective and more opportunity to really reduce or prevent the development of impaired kidney function in people with type 2 diabetes. This has been suggested initially with the rewind post-hoc analysis, suggesting a 25% reduction hazard in terms of the composite kidney function. And you can see here the distribution in terms of people with and without albuminuria, and in people with a GFR lower or higher. And you can see that there's already much of a difference in terms of what is the overall effect in these individuals, irrespective of the starting point in terms of GFR, in terms of albuminuria. Now, as far as GLP-1 receptor agonists, have the result of the FLOAT trial, evaluating the effect of a semaglutide in terms of multiple endpoint in people with a chronic kidney disease. But I like to emphasize for you what is the effect in terms of prevention of the reduction in the loss of GFR through the time, as you can see here, which is very much reminiscent of what we have been observing with SGLT2 inhibitors. And here is an example in this specific case in Credence and Canvas as far as the GFR changes is concerned in people on placebo, showing this continuous and progressive loss of GFR and this initial reduction in GFR, but then the flattening of the curve using canagliflozin. And this is a prevention or preservation of glomerular filtration rate that seems to be irrespective of what is the starting point, the health, the kidney health status of these individuals. This is the overall effect in terms of a reduction in the loss of glomerular filtration rate, which remains almost the same irrespective of what is the baseline GFR. And you can see that even in people with a normal GFR, there is still a protective effect in terms of loss of GFR over the time. The same is true for albumin excretion rate, although there is a greater effect in people with more advanced with microalbuminuria, but also is still present in people with a normal albumin excretion rate. It is the same if you classify the population in terms of the KDIGO, low risk, moderate risk, and high risk. Even in people with low risk, and even more, even in people with very low risk, there is still a protective effect in terms of the GFR. And the same is true in terms of albumin excretion rate, because here is the effect of dapagliflozin in people with a normal albuminuria, with a microalbuminuria, with albuminuria and overt albuminuria. And you can see here that even in people in the early stage of their kidney disease, there is a protective effect in terms of development of albuminuria. And I think, that it's important to realize that preventing the progression of GFR and albuminuria can be quite important. But to support the use early use of these treatments in the population are data that comes from the real world. These are data that we have produced in Italy. This is a study involving 62,100 people with type 2 diabetes that have been selected by propensity analysis, comparing the effect of SGLT2, in this specific case, dapagliflozin versus a non-SGLT2 treatment. But bottom of the line, what I'd like to really point out to you, that this is a very early population with only 6% with a CKD and 15% with albuminuria. So nearly we are in the early phase of the disease. And again, in this population too, there was the evidence for the protective effect of dapagliflozin, of SGLT2 inhibition, both in terms of a loss of GFR and in terms of progression of albuminuria. And this is important because, as I mentioned, the progressive loss of GFR and the increase in the albumin excretion rate are independent risk factor for cardiovascular mortality, for coronary heart disease, and for heart failure. So preventing the development of diabetic kidney disease, preventing the loss of glomerular filtration rate, preventing the development of albuminuria can prevent the outcome in terms of the kidney complication, as indicated here, in terms of the distribution of the protective effect of dapagliflozin in people with a different degree of risk according to the KDIGO stratification process. And you can see here that what can be observed in the overall population is retained also in people with a low risk in terms of kidney-specific composite outcomes, but also it's true when you do consider the cardiorenal composite outcome. Again, you can see here that even in people with a low risk, there is a protective effect. So supporting the use early use of this treatment in the prevention of cardiorenal disease in people with type 2 diabetes, which fits exactly with the recommendation of the KDIGO. The KDIGO, in terms of recommendation to improve outcome in patients with diabetes and kidney disease, recommend as a first line SGLT2 inhibition together with metformin if the GFR allows, but SGLT2 inhibitors to be initiated for GFR above 20 ml per minute and even more in people with normal GFR. So let me try to recap what I learned from landmark cardiovascular outcome trial. What I learned is that, at the time I made the diagnosis of diabetes, I need to have a very clear goal. And the clear goal is to prevent complication, prevent microvascular complication, and prevent macrovascular complication. To do that, I need also to ensure long-term glycemic control. And long glycemic control can be achieved by using glucose-lowering agents, can be effective and are associated with the low side effects, hypoglycemia and body weight gain. Because if you can reduce the side effects, you can improve adherence, and maybe you can also improve clinical inertia, which all contribute to sustain long-term glycemic control. But in doing so, I can also select drugs earlier on with ancillary non-glucose properties that can contribute to prevent the development of microvascular complication. And as I mentioned, we have now SGLT2 inhibitors, we have GLP-1 receptor agonists, and from this point of view, this can be really seen as disease modifying because they can reduce the risk of progressing toward microvascular complication, and in particular, the diabetic kidney disease, because the diabetic kidney disease is a sort of a marker for overall, for systemic small vessel disease that can occur in the heart, supporting also the risk of developing heart failure, but it can also contribute through the reduction in the development of albuminuria and by reducing the loss of glomerular filtration rate in preventing the macrovascular complication. So I think nowadays we have a better solution, and this better solution has been testified, has been witnessed by solid results coming from landmark cardiovascular outcome trial performed in people with type 2 diabetes. And with that, I thank you very much for your attention.